Hello, and welcome to our ENDO 2024 news conference on reproductive health. I'm Jenny Glenn Gingery. I'm the Director of Communications and Media Relations here at the Society, and we're so pleased to have all of you with us today. Today's news conference, again, will explore the latest research on reproductive health being presented here at ENDO. We're pleased to have with us Dr. Diana Blythe, Program Chief of the Contraceptive Development Program at the Eunice K. Shriver National Institute of Child Health and Human Development, Dr. Bonnie Grant of Imperial College London, and Dr. Eleni Armeni of Arteo Hospital National and Kapodistrian University in Athens, Greece is joining us remotely. Over the next 30 minutes, each speaker will present their findings, and then we'll be wrapping up with a Q&A session. Please note that this news conference is being live streamed, and many journalists are online with us right now. Welcome to all of you. Because we're live streaming, please make sure that you make any of your remarks into a microphone, just so that our friends who are joining us remotely will be able to hear you. And journalists who are attending online, you can type any questions you have into the chat window, and we will take those during the Q&A portion of today's event. I'd now like to invite our first presenter, Dr. Blythe, to speak.
Well, hi. Thank to the group for inviting us to present our data here. And I'm Diana Blythe, and as you can see from all the authors on this abstract, it takes more than a village to be able to do this kind of work. So disclosures are that we have some cooperative research and development agreements with various pharmaceutical companies and hope to have more in the future. This is the typical effectiveness for a variety of contraceptive methods, with the top tier being the most effective, the long-acting methods, the mid-tier being middle effectiveness, and the low tier, which require use with each active intercourse, having the lowest effectiveness. The existing male methods include vasectomy, which is very effective but not easily reversible, and male condoms, which has a high failure rate and is not very acceptable. So men need and want more options, such as an effective reversible male method. And in the contraceptive development program, our mission is to develop products. This is a bit of a pipeline of the research that's going on in 2024. We have products in the pipeline for women. Some of them have actually been approved and are on the market, and others are in development, including in phase 3. And we have products for men. The one that is the furthest along of any male method that I'm aware of in the world is the Nesterone testosterone gel. And that's what I'll be talking about today. So first I'll start with sperm numbers. Men make 1,000 sperm per heartbeat, which is a lot. And the normal sperm count is between 15 and 200 million per mil. About 1 out of 10 million sperm enters the fallopian tube, attaches to the wall, and undergoes capacitation to be able to fertilize an egg. And you've heard it only takes 1. However, sperm concentration of less than 1 million per mil is effective for contraception. Now, how does this work? This uses the typical hormonal approach which we use for female methods, which is to take advantage of the feedback loop in the hypothalamic pituitary gonadal axis. In this case, we have a typical male pathway, and you can see that GnRH is stimulating the pituitary to make LH and FSH, and LH is responsible for a very high amount of testosterone in the testes, about 50 to 100 times what circulates in the blood. If we add a progestin, similar to what we would do for a female, we block those hormones and we can stop the production of testosterone in the testes, and that stops spermatogenesis. However, it also lowers the serum testosterone below a certain level, and that would stop additional functions that are dependent on androgens, such as sexual function. So we need to replace the testosterone in the normal physiologic level And as I said earlier, it's sort of a Goldilocks, not too high, not too low, just the right amount of testosterone for maintaining everything in the blood. So the testosterone gel combination has now been concentrated into a single pump where both hormones are administered in a single dose. Each actuation of the pump delivers about 2.5 milliliters, or about half a teaspoon. And the product is applied to the shoulders, similar to the instructions for androgel for testosterone replacement in men. That early work led us to develop the amount of nesterone and the amount of testosterone that we would like to have in the gel, and that allowed us to get into a later phase clinical trial in which couples use the method of contraception. This is a fairly long time commitment, almost 2 years, because it requires screening and suppression of the sperm, and then an efficacy phase of up to a year, and a recovery phase that lasts from 8 to 24 weeks, depending on the individual. Our target is 200 couples completing 1 year of efficacy. And the primary endpoints in this study are prevention of pregnancy. The secondary endpoint is safety, side effects, and acceptability to both partners. And this trial is being conducted around the world. Well, at least in the United States, South America, Europe, and Africa. So I just want to review what the men go through in their participation in this trial. It requires 2 normal sperm counts greater than 15 million per mil. At week 0, the male partner begins the daily application of the gel, and sperm counts are obtained every 4 weeks as we watch the sperm decrease down to what we hope will be 0. They need 2 consecutive counts of less than 1 million per mil to enter efficacy. E with a number here shows the week that a couple enters efficacy, and at that point they stop using any other method to protect against pregnancy. So this method becomes their contraceptive method. R indicates that the couple has completed 1 year of efficacy, the man stops using the product and enters recovery, and we follow the sperm counts to return to normal levels. So our initial thought, based on previously published data, was that it would take about 12 to 15 weeks for suppression to occur, because an integrated analysis of 30 studies showed an average of about a median of 11.7, and the testosterone undecanoate studies that were done in China showed a median of 15 weeks, and the Baer et al. Study that was done by the WHO had about 12. It was not exactly easy to pinpoint, so we give a range of about 10 to 13. But what we were seeing actually was less than 8. So if you look at this timeline, this is the timeline of suppression according to week that we see for the percent of men in our study suppressing to less than 1 million. And if you look at this in comparison to other studies, by 12 weeks, we have about 80% of our subjects fully suppressed, and by 15 weeks, it's close to 90%. So that's exciting because it will make this product more attractive, and in fact, we may be able to even show a faster suppression if we have more time points at the earlier portion of this timeline. We weren't expecting this, so we didn't measure at 4, 5, 6 weeks on everybody, and we don't know how many of them actually might have been suppressed prior to 8 weeks. So comments from the completers. From the male participants, it was easy. It's something I've always wanted. It became part of my routine. I wish I could keep using it, and so forth. My particular favorite is, can I re-enroll in the study? Because this is a 2-year study, and this is a long time, a lot of visits, and the fact that the men want to continue and they want to remain in the study, I think it is an endorsement for the product that's stronger than anything I could convey From the female participants, it was better for my relationship. For me, I'm much happier, and I wish I didn't have to go back on my old method. And a lot of the women, as they get to the end of the efficacy period, are really expressing that quite a bit. And Cosmopolitan did an interview with some of our couples, and they showed, in the interview, I think it's a much stronger voice to hear from the participants about what it meant for them to be in the study, particularly the women, because this is actually a women's health issue in addition to being a male health issue. So this product is effective, reversible, safe, acceptable, and user-controlled. And where is it going next? At this point, the next step is to meet with the FDA. They haven't had to provide guidelines for approval for a male method because nothing has reached this stage. So they haven't provided it yet, and we hope they will provide it when the study's still ongoing. We hope to finish by the end of the year and present the data to the FDA and then get their guidance on the path to approval. The next step will be phase 3. And I just want to acknowledge all of my many participants, investigators who participated, in particular the Population Council, who have been a partner throughout this entire process, led by Regine Sidrick-Ware, and by the 2 principal sites that direct male contraception, the University of Washington, led by Stephanie Page, and Lundquist Institute at Harvard UCLA Medical Center, led by Christina Wang. So thank you, and I'll take questions later when it's time. Oops.
Thank you so much, Dr. Blythe. I'd now like to invite Dr. Grant to present.
Hi, morning. Thank you for the opportunity to present our research today. We're looking at sexual and mood symptoms in men who have stopped anabolic steroids. I've got no disclosures. So I'm going to be talking about how this is the first study quantifying the symptoms looking at men who have stopped anabolic steroids, and will show that past users who have stopped within the last year have worse depression, anxiety, and sexual function. And this is 2 to 3 times worse depression in men who also have a psychiatric diagnosis. And interestingly, higher LH levels are associated with worse sexual function. So what are anabolic steroids? So these are drugs that have a testosterone-like effect, and they're primarily used by men with the aim of increasing muscle mass and used for aesthetics and bodybuilding competitions. It's been estimated that around 6.4% of men worldwide will use anabolic steroids at some point during their life, but it's worth noting that this data came from a lot of studies focused in gyms. So we know that when men use anabolic steroids, there are a number of physical adverse effects that occur during use, most of which are fully reversible. So this includes very thick blood, enlarged hearts, hypertension, and infertility. Qualitative studies have shown that when men stop, they report higher rates of depression, sexual dysfunction, and even suicidal ideation. And around 30% of men will go on to develop a dependence syndrome, so an addiction to anabolic steroids. And about 65% of men will restart within the first year. This is more likely if they feel that they're addicted and report lower well-being scores. So this first year when stopping is really important because we need to determine what it is that causes these men to restart using, and perhaps there's targeted treatment in there. So we want to investigate how severe are the symptoms within the first year and what factors might predict their severity, so we can ultimately come up with some treatments. So one of the clues may lie in the male gonadal axis. So as has already been mentioned, under the influence of GnRH, the pituitary will release LH and FSH, which act directly on the testes to produce testosterone and induce spermatogenesis. As a form of exogenous, so outside the body testosterone, anabolic steroids suppress this whole system and will switch it off. So the pituitary will stop releasing LH and FSH, and the body will stop producing natural levels of hormone, and it will completely be shut off. What we know from current studies is that even when men stop using anabolic steroids and this testosterone is taken away, it can take anything from a couple of months to even up to a year or more for normal testosterone to recur. And it may be that this period of low natural testosterone in men is what causes them to have sexual dysfunction and low mood and energy. So what did we do? So we've performed a cross-sectional study across 3 sites within the UK, and in total we have recruited 245 men. This includes men who have never used anabolic steroids, are currently using, and have used within the last year and stopped. At a single visit, they completed a very detailed questionnaire asking them about their anabolic steroid use and other substances, and validated patient questionnaires looking at mood, sexual function, and anxiety. And they had a morning blood test and a urine sample, which will be tested for toxicology. So firstly, when we look at the 3 groups, we find there's no difference in age or ethnicity between the men who have never used, are currently using, or have previously used. But interestingly, men who are currently using or have previously used have much higher rates of psychiatric diagnosis, which they have self-reported. This is primarily depression and anxiety. Also, men currently or previously using report much higher rates of other illicit drugs, which is most commonly cocaine and cannabis. When we look at their hormone levels, it's unsurprising that men who are currently using anabolic steroids have much higher levels of testosterone compared to men who have never used or have previously used. So a normal level for a man is around sort of 10 to 30. And again, unsurprisingly, as I've described, their LH and FSH levels are very, very low compared to men who have never used or have previously used. There's no difference in the mean testosterone between those who have never used or previously used. However, about 25% of men who have stopped have a testosterone level lower than normal. So firstly, we looked at depression scores. So this was measured by something called the Beck Depression Inventory. So just to orientate you, a higher score indicates worse depression, and it's that of 63. And this could be normal, mild, moderate, or severe depression. And in men who have previously used anabolic steroids who have stopped within the last year, as shown by the blue dots on the left, they have a much higher depression score and therefore worse depression when compared to men who have never used. And if we take the men who have moderate or severe depression, those who have stopped is 20% of men, those who are currently using, it's 6% of men, and those who have never used, it's 0. So there's much more in the previous users who have moderate or severe anxiety. We then went on to perform a multivariable analysis, so we looked at lots of variables and whether this would predict the worst depression. And we found that in men who are currently using, they have a 2 times higher depression score if they also have a psychiatric diagnosis compared to men who do not. Equally, in those who have previously used anabolic steroids and stopped, they have a 3 times higher depression score and worse depression if they also have a psychiatric diagnosis. Interestingly, testosterone levels were not associated with level of depression. Secondly, we looked at sexual dysfunction. This is measured by the International Index of Erectile Function, and in this case, a higher score equals better sexual function. So you can see in those who have stopped by the blue dots, they have a worse sexual function and a lower IIEF score compared to men who are currently using. There was a very weak correlation between total testosterone level and IIEF scores. And when we performed a similar multivariable analysis, the only significant variable that came out was LH. So in men who have a higher LH score, they have worse sexual function. Finally, looked at anxiety scores as measured by the Generalized Anxiety Depression questionnaire. And again, a higher score indicates worse anxiety, and there's grades from normal up to severe. And in men who have previously used, they have worse worse anxiety scores compared to men who have never used. And 12% of men who have previously used are experiencing moderate or severe anxiety, compared to only 2% in the non-users. So we've performed the first detailed quantification in the first year of anabolic steroid cessation, And this is important as 2/3 of men will restart using anabolic steroids within the first year of stopping, and this is a potential target for treatment for men in the future. Due to the large number of men that we managed to recruit, we were able to perform a multivariable analysis looking at what may predict this. And we have urine samples from all the men where we're going to perform toxicology to look at the presence of illicit drugs and also anabolic steroids in their urine. We are limited by recall bias, particularly in men who have stopped, as some of them may be trying to recall what they used from over a year ago. We also can't be sure how much is a placebo effect as a result of using the anabolic steroids. And importantly, we don't know what their baseline mood or sexual function was before they started using. So in summary again, so men who have stopped anabolic steroids have worse depression, anxiety and sexual function. And this is 2 to 3 times worse in men using anabolic steroids previously using with a psychiatric diagnosis. Interestingly, higher LH levels were associated with worse sexual function, and we propose this may be that there were some men in this group who had very, very low LH levels, perhaps due to ongoing concealed anabolic steroid use. We'll be able to decipher this when we do the toxicology testing, and it'll be interesting to see if this still stands true. We're hoping that this information will allow for future studies to be developed to design treatments which will help millions of men worldwide to stop and stay off anabolic steroids. Thank you.
Great. Thank you so much, Dr. Grant. So now I'd like to invite Dr. Armini to present.
Thank you very much. So, let's go ahead. Dear ladies and gentlemen, my name is Dr. Armini, and I will present the results of a research, latest project actually, that has taken place at the second Department of Obstetrics and Gynecology, University of Greece. So overall, the implications of the menopausal transition to the female health are depicted in this current slide. Accordingly, as the time is passing by, the change in hormone levels, and particularly the loss of ovarian follicles and their function, decrease in inhibin beta, AMH, and estrogens, as well as the desynchronized secretion of GnRH, FSH, and LH, will result into the loss of the menstrual cycle, vasomotor symptoms, urogenital atrophy, mood and sleep disorders, but also
Sorry, thank you.
cardiovascular disease and we call as menopause. The menopause has been associated with various implications, as we saw in the previous slide, and one of those is the cardiometabolic effect, which cannot exclude the liver. Adiposity, metabolic syndrome, and insulin resistance have been associated with an increase in levels of cytosins and an age-related, rather, decrease in levels of sex hormone-binding globulin. Progressively, these changes result into an increase of oxidative stress and a decrease in anti-inflammatory oxidants, with a consequent implication, the increased prevalence of non-alcoholic fatty liver disease, we can progressively develop into non-alcoholic steatohepatitis or even fibrosis. Recently, the multi-society Delphi consensus tried to analyze a different approach into the nomenclature related with fatty liver disease, and in particular, the dynamic spectrum of steatotic liver disease has now been divided into the metabolic-associated steatotic liver disease, the metabolic-associated but related with alcohol intake part of steatotic liver disease, and the pure alcohol-related steatotic liver disease. The difference is the increased emphasis into the rolic factors, which are highly prevalent
in women and after the time of the menopausal transition. All of these parameters are to be found in women after the menopause. With regards to genetic risk, well, we shall look at this at a later point of time, but cardiometabolic is what we will focus on today. Therefore, this study aimed to investigate, first of all, the prevalence of metabolic dysfunction-associated steatotic liver disease in a group of peri- and postmenopausal women, and the possible link with vasomotor symptoms. This is a cross-sectional study that included 106 peri- and postmenopausal women selected from a university menopause clinic. The investigations performed included the evaluation of the severity of climacteric symptomatology using the validated Green Climacteric Scale, as well as the steatotic liver disease assessment by using an indirect indicator at this stage, the fatty liver index. The fatty liver index is a validated algorithm that has been established in 2006 by an Italian group and validated progressively in many studies thereafter, according to which a cutoff of equal or higher than 60 is associated with a risk for steatotic liver disease of at least 78%, whilst a cutoff lower than 30 is associated with absence of liver disease. This is the algorithm I'm referring to for the fatty liver index. So we defined metabolic dysfunction-associated steatotic liver disease by the presence of steatotic liver disease, which was explained in the previous slide. The presence of at least of the following risk factors: L, to be out of range, 2 diabetes or intake of hypoglycemic treatment, raised blood pressure or respective treatment, as well as high levels of triglycerides or relevant treatment. The results show that metabolic dysfunction-associated steatotic liver disease is prevalent in 17.1% of this group of peri- and postmenopausal women. We try to various biochemical and anthropometric parameters, as well as the prevalence of vasomotor symptoms between the group of women with metabolic dysfunction-associated steatotic liver disease and those with no liver function. The differences were notable with regards to obesity indices, which was to some extent anticipated, as well as triglycerides and the fatty liver index. The remaining parameters did not differ. However, a borderline difference that was originally observed when it comes to vasomotor symptoms, when it comes to climacteric symptoms, became significant when we did a separate analysis, particularly for vasomotor symptoms, which is hot flashes. Particular, we identified that in the sample of women, comparing those with moderate, so to the no or mild vasomotor symptoms, the risk for metabolic dysfunction-associated liver disease was 3.2 higher in the most symptomatic, lower of 12.5% in those with severity. Trying to reanalyze a sample, we restricted analysis those who were only perimenopausal or 5 years after the final menstrual period, which means early. That was a total of 7 women. But even more pronounced difference, whereas women with too severe symptoms, the risk for metabolic-associated liver disease to those with no or mild symptomatology. On the other side, we also tried to divide the sample into metabolic dysfunction-associated liver disease and those without, and the difference remained to be significant, assessing for the presence of moderate to severe vasomotor symptoms. That means The women with an accumulation of cardiovascular risk factors with implications to the liver had 57.9% risk for moderate to severe vasomotor symptoms in comparison to women with no indication of metabolic dysfunction-associated liver disease who had a lower risk for moderate to severe vasomotor symptoms. Translate into an odds ratio of 1.7 when it comes to the risk for moderate to severe vasomotor symptoms in women with or without metabolic dysfunction-associated steatotic liver disease. Our analysis is limited by the small sample size, so this is in principle a cross-sectional first and also pilot study, but there are future steps to be taken, which means to re-evaluate the results using ultrasonography of the liver in order to confirm the validity of our findings. However, these results are strongly indicative of the fact that aging and estrogen decline, which is known to be associated with higher risk of insulin resistance, type 2 diabetes, and cardiovascular disease, is important enough to also affect the liver. It is important that metabolic assessment takes place during the consultation of a peri or postmenopausal women, especially when the point of discussion is the possible consideration of hormone replacement therapy, which in women who have a higher cardiovascular burden would cause a potential destabilization of the balance that has been already achieved. Therefore, it is important not to omit assessment of severity of the symptoms, including also severity of liver disease, which can happen using easily and for free available algorithms. In conclusion, the association between the vasomotor symptoms and metabolic dysfunction-associated steatotic liver disease diagnosis in middle-aged women is present regardless of the use of HRT, and it is important to remember that cardiovascular risk evaluation should take place at midlife, especially for those women that experience the most troublesome vasomotor symptoms. I want to thank my team and my colleagues from Greece for this about our research. Thank you very much.
Thank you so much, Dr. Armini. We really appreciate you joining remotely. Great. I'd now like to turn things over to Colleen Williams, our Senior Communications Manager, who's going to run the Q&A session.
Great. Does anyone in the room have a question before I move to the online? Okay. So this question is for Dr. Blythe. What are the next steps in this research?
Can you hear through here, or do I have to get closer?
I can hear you. Yep.
Well, we hope the next step is a phase 3 clinical trial leading to approval of this product. Our immediate next step is to finish the phase 2B trial, which we will do before the end of the year. Most of our couples right now are still in recovery or exiting, and then we have to lock the database, clean the data, analyze the data, publish the data, and so forth. But in the meantime, we are communicating with the FDA to figure out what the phase 3 design will be, because as I said, they don't have guidelines yet, and they'll need to develop them for us.
Great, thank you. You have a question?
Dr. Blythe, just a few questions about dosing. So the man applies it every day, same dose every day, even after sperm suppression. What happens if the couple then decides they want to get pregnant? How long after he goes off of it? And then what if he misses a dose?
If he misses a dose, nothing happens. Everything is just fine. At the end of the trial, the recovery is about, well, if he were to stop using the product completely, then he would go into recovery, and it's not as though the sperm are all waiting to get out. They have to be made, and the life cycle is about 70 days. So that's when we start to see sperm recover. And after we start to see the initial sperm, we see full recovery pretty quickly. In our study, we've had quite a few couples who decided they wanted to get pregnant after they finish treatment, and they've done so, and we have lots of babies now. In my longer talk, I have a little picture of lots of babies. That it's not part of the protocol to have return to fertility, but we don't anticipate any problem because in order to exit the study, they need to have a normal sperm count that's similar to what they had when they came.
Great. I have one question online here for Dr. Grant. How long does sexual function and mental health symptoms of steroid withdrawal typically take to resolve on their own? After your study, what sort of supports do you think might help steroid users quit?
Thank you for that question. So to address the first point, we don't actually know how long they experience symptoms of depression and sexual function for. There has been some other studies that have looked at men who have stopped 2.5 years ago and they still are experiencing some symptoms. But there's not any studies that have looked at individual men and followed them up over sort of multiple months or years to see how long it takes. So we don't know, is the answer to the first question. And sorry, just repeat what the second part was?
Sure. The second part, after your study, what sort of support do you think might help steroid users quit?
Yeah, so I think more studies need to be done, but I think ultimately the support is going to look like something that addresses perhaps some of the hormonal aspects, but a big part of it is going to be what's addressing the psychiatric aspects. So it's probably going to be a joint treatment between sort of physicians and also psychiatrists as well, and that would be the best model.
Okay, great. Thank you for that response. I have one question for Dr. Armini as well, if you can hear me okay. In light of the research, what advice do you have for women experiencing menopausal symptoms?
Sorry, can you repeat the question?
Sure.
I cannot hear it very well.
In light of the research, what advice do you have for women experiencing menopausal symptoms?
Thank you very much. So in light of the results, my advice is to not try to just grin and bear the menopausal symptoms. Go to your doctor, ask to be assessed, and the assessment should not only include the possible treatment options, but should be more generalized, holistic, if I may call this so, because your symptoms might be implicating prediabetes, raised inflammation,
I think I might have lost you a little bit there with the internet connection.
With high cholesterol.
Oh, there we go.
Should I repeat it, the answer?
Oh, no,
Can
we
you
can
hear
hear
me?
you now. Yep.
Hello, can you hear me?
Yes. Yep.
Okay, great. So I will keep it short now. Basically, it's not to forget yourself. Look after yourself, speak with your doctor, and go and get checked. By getting checked means not only keeping a healthy lifestyle, but have a screening done for cardiometabolic risk factors in order to ensure everything is healthy. And after that, you can start your hormone treatment as you wish and as you need.
Great, thank you. Any other questions from anyone in the room? Sure.
This is a question for Dr. Blythe. Did your subjects report any negative side effects to the gel?
The side effect profile has been really pretty good. There have been a few complaints, some associated with steroid, with what we would expect from androgen therapy. But generally speaking, the side effect profile has been better than we projected. It might be from, effects that women may experience on hormones. So we're pretty encouraged by that.
Great. Another question? Sure.
For Dr. Armini, how does body mass index factor into this relationship?
One more time, please. One question.
How does body mass index factor into this relationship?
The there is an association, obviously, between body mass index, especially in central weight accumulation, and increased risk for vasomotor symptoms, as well as increased risk for fatty liver disease. But because of the fact that these associations were also remaining independent of body mass index only, it does not mean that someone is protected from fatty liver disease if they are slim. So there is a role, but it's not an absolute rule that if the body mass index is not raised, you will manage to get away from fatty liver disease if you enter the menopause.
Great, thank you. All right, I think
If
we're
I could
all.
ask
Oh,
one
sure.
quick question, sorry. A journalist had asked us earlier, Dr. Blythe, and I was quite curious, is there a particular reason the gel's applied to the shoulder blades?
The gel could be applied other places. In the earlier development portion, we had the Nesterone, when they were two separate gels. The Nesterone was applied to the abdomen, the testosterone to the shoulders. When the gel was combined, we decided to recommend what is currently recommended for androgel or other testosterone replacement gels, which is to the shoulder and the back. In particular, because it minimizes the transference to the partner. It's easy to cover up with a shirt and minimize transfer to, hugging children and things. Whereas if you had it kind of everywhere, you have to worry more about what gets covered up. So it's a good place for absorption, and it's an easy place to cover up or later shower off and so forth. And it doesn't work better if you put it other places. So
Great, thank you.
Great. I think that's all the questions we have for now.
Wonderful. Well, thanks so much to everyone who joined us for today's event, and we hope you enjoy your second day here at ENDO 2024. Thank you.